Are my slides still visible? Just want to confirm, anybody? Okay, thank you. Sorry for that. I just want to be sure. And I'll put it back in full screen, in full screen mode shortly. But I want to say that as an advocate of decolonial praxis in global health, the perspective that I take is really a pragmatic perspective. So I look at the lived experiences of people like me who are global practitioners, global health practitioners in low and middle income countries. And I'm particularly interested in how the practices of certain key actors across the global health ecosystem enables, entrenches, and perpetuates these power imbalances, particularly between practitioners and institutions in the global north versus those in the global south. And like in any development domain, there's a wide range of key actors. So in global health, we have funders, we have international NGOs, we have academics and researchers, scientific journals, policymakers, civil society, the media, etc. Right? So there's a wide range of stakeholders in the global health ecosystem. But I just want to focus on two groups because I believe that they hold the most power and in many ways are the most culpable for these power imbalances that we experience in the practice of global health today. So I'll start with funders and then international organizations and other research organizations. So I acknowledge that this is not a homogeneous group. These are not homogeneous groupings, right? Funders vary from, local funders to government-backed funders, et cetera. Private charities is a wide range, right? But they tend to share common characteristics and behaviors, and they hold tremendous power over the practice of global health because they set the agenda, they decide how and to whom resources are allocated. And historically, even though the target population of many of these funders are here in the global south, the primary recipients of their resources have been in the global north. Yes, there is an argument for lack of capacity in the global south, whether it's a technical capacity, even administrative or operational a lack of capacity. And this is a fair argument. But what we are seeing increasingly is that even when local capacity exists, we continue to see this bias that some funders have towards institutions and practitioners in the global north. And one very typical example is if in 2021, just last year, there was a consortium of 7 institutions, all in the global north, that won a $30 million grant for a malaria program in Africa, not in the UK, not in the US. This was a malaria program in Africa, right? And yet, all the 7 institutions that won this grant were in the global north. Now, 20 years ago, maybe this would not raise eyebrows. We might argue we were in the bush, we didn't have steamer, we were dangling from trees, whatever, I don't know. But in 2021, this is absolute madness. Because as far as I know, there are a good number of African institutions and African experts who have a strong track record in malaria programming. So what went wrong in that situation? And maybe the funders will argue that their process was meritocratic, it was transparent. But that's the thing. If you don't open your eyes to these biases or these power imbalances, you simply will not see them. And that's why the organization that I represent, and I'll tell you a bit more about it later, we recommend that funders need to re-examine their grant-making practices and their prioritization mechanisms. Who sits at the table within these organizations matter. If you have, for example, a proposal review panel that is made up of all people from a particular part of the world, or if you have a board that is comprised of mostly people from one part of the world, but perhaps you have 1 or 2 token people from the global south, then you don't be surprised that these biases are creeping into the way you do things. For example, on the issue of board constitution, one of my members, who is the executive director at one of the leading global health think tanks here in Kenya, she was appointed to the board of a leading funding organization. And do you know that she single-handedly influenced that organization to develop a policy that shifts the balance of funding Initially, they were funding around 30, 40% of their work in low and middle income countries, of organizations in low and middle income countries. Even though all their work was in low and middle income countries, most of their funding was going to institutions in the global north. But because of her appointment to that board, she pushed an influence for them to shift that balance of funding. And right now, about 70% of their funding goes to institutions in the global south, right? And that is written into their policy because she was at the table. If she wasn't at that table, that imbalance, and I believe an unfair imbalance, would have continued. The second group I'd like to address are international NGOs and academic institutions, think tanks, etc., civil society. To be fair, there will be no global health without these institutions and their employees and their teams. A lot of the successes that we've seen in global health over the years, including the massive reduction we've seen in under 5 mortality, even here in Africa, controlling HIV, which was killing so many people, we have to acknowledge that global health organizations, international global health organizations, of course, in partnership with their local partners, have played a very significant role in those efforts. And yes, some of them, they trace their origins, I won't say which ones, to colonial era, but a lot of them have transformed into modern organizations. But we still see some remnants of that colonial mindset in how some of these institutions and their employees operate. For example, you've probably heard of parasitic or parachute research. And this is not research about parasites or about parachutes. Rather, it's a situation where a researcher, an academic from the global north flies into Africa, does their thing, does their research, takes the data, goes out, publishes in the best journals, and just acknowledges the local partners in kind of 1 or 2 sentences in the footnotes of that publication. And you'll be surprised that even in this day, even in 2022, this kind of behavior is still happening. So this kind of attitudes, it's rooted in what they call a saviorism mindset. You know, these poor local people need to be saved, and we are the ones who are going to fly in and save them. And yes, sometimes we do need to be saved, but the problem with that mindset is that it creates a sense of entitlement and superiority, right? And this manifests in how these relationships and these power imbalances and power dynamics tend to play out between colleagues in the global north, institutions in the global north, and those in the global south. I've personally been victim of this mentality. Many years ago, I was implementing a research project in the informal settlements here in Kenya, in collaboration with some partners in the global north. And, you know, first of all, this is the institution that I was working for at the time. We were never informed by our partners in the global north what the total value of the grant they got was. They had received a grant from a private donor. They didn't tell us how much it was. They just said they got a generous grant and they have X amount to give to us. Now, we were desperate. I mean, I can speak for myself. I was desperate for funding. My job sort of depended on it. So obviously, I was like, Sava, let's take the money. But I'm telling you, I had to endure quite a bit of bullying by these colleagues. My knowledge of the local context was basically rubbish, to be honest, because for them, all that mattered was their scientific and technical superiority. You know, for example, I insisted, and some of you might know that, you know, randomized control trials, for example, are the gold standard of, you know, research methodologies. Let me put it that way. But they insisted on doing an RCT in that community. And I told them, look, I've been working here many years. This RCT will not work. It's not practical. Even just from a socio-cultural perspective, the community is going to fight this. They're going to resist this. Fell on deaf ears, right? It's only when things began to play out, fortunately, we had not gotten into the field, that somehow they saw reason and changed their minds and allowed us to go with a different design that was more pragmatic and more socio-culturally acceptable in that community. But honestly, that experience, it left a very bitter taste in my mouth. And I've left that organization, but I still have that bitter taste in my mouth till this day. And my story is not unique. So again, the movement that I belong to, we have some practical recommendations. Excuse me. And what we are asking these international organizations is that, look, again, you need to look at who is at the table. Look at your hiring and recruitment practices. Look at your policies. What kind of biases are built in? And for example, when you think about recruitment policies, some look at things like salary history. They look at letter of recommendations. These seem like harmless practices, right? But look, these things have been shown. There's proof that they tend to favor people who, come from a certain part of the world, right? You can get a letter. What are the chances of me here in Africa getting a letter of recommendation, let's say, from a Harvard professor, or my chances are slimmer compared to someone from those sides, right? And so if an international organization puts a lot of emphasis on letter of recommendation, for example, and who writes the letter of recommendation, then automatically I am disadvantaged. And that means they will keep hiring a homogeneous group of people, right? And then these are the kind of things that create these biases and some of these mentality. So we advocate for them to think about who is there at the table, look at their policies, and see how they can change things. At individual level, we suggest that they need to re-educate themselves, because unconscious bias there's a reason it's called unconscious bias. These are things that we don't even know. They look harmless to us, but they might be harmful to the people that we work with, and their training programs that can help you uncover some of these unconscious biases and begin to be mindful about them. And for us, we say that it always starts with humility. And we tell our partners in the global north that, when it comes to working in the global south, you should actually see yourself as the lesser partner. And I know this is going to be a controversial point. I know I might be burnt at the stake for saying this, but think about it this way. Regardless of how much technical ability you have, if there was no context to apply that technical ability, it would be really of no value, right? So the context, in the context of global health and even international development, context is king. Or if I'm going to be more gender sensitive, context is king, queen, and everything in between. Context is key, right? What are the chances that I, as an African, will go to Belgium and say, I'm an expert on Belgian issues? What are the chances? Regardless of what I know, regardless of my technical ability, even if I'm a genius, what are the chances that I'll go to Belgium, for example, or go to Canada or wherever, and just say, me, I'm an expert in Canadian issues, or I'm an expert in British issues? But we see the reverse a lot. And yes, I know there's some historical reason to that. And I know legitimately there are people who can be from one part of the world and be experts in another part of the world. But that card, I think it tends to be overplayed, and it tends to create some of these colonial mentalities and practices that we see. So in that sense, I'm saying when it comes to issues in the global south, you should actually see yourself as the lesser partner and elevate your partners in the global south as the experts in the context, at least contextual experts, as experts in their particular context. And when you look at it that way, you start to give more weighting to their contributions. This invisibilization of a lot of our global south researchers in scientific papers is really sad, and it needs to end. You contribute, but because you're not the one who brought the funding, etc., your name is lost somewhere in the middle of the authorship. But if you change that mindset and see yourself as the lesser partner, then you begin to put more weight to the contributions of those in the context where you're working. You will ensure that they get a fairer share of the budget. You won't do what that institution did to us and decided out of the grant that they got that they're going to give us a fraction. Till today, we don't even know how much it was. They could have gotten 10 million and we got, let's say, 100K. We don't know, right? But if they saw themselves as, the supporting partner, let me use that term, maybe to be more politically PC, right? Then if they saw themselves as the supporting partner, they'll say, look at the entire budget. What do you think would be required for this particular project that we are proposing in this particular context. And we are not criminals. We would have told them, look, for this particular work, this is what we feel, right? And I think that would have been a fairer approach. So, I think it's very critical for us to, for these two constituencies in particular. It also applies to journalists. It applies to the media. The way the media captures and reports issues in the global north regarding global health, it really needs to change. So let me put back my screen as I wrap up and tell you about this global health decolonization movement and what we are doing. So we are really trying to advocate for decolonizing global health, and we're doing it through three strategies: coordinated advocacy, strategic communications, for example, what I'm doing now, speaking about the issue, and hopefully one day, this is really aspirational for us, patient capital, that we persuade African governments and their development partners to invest in reforming the global health landscape. And some of the things we do, I talked about strategic communication. We've hosted some webinars in the past on decolonizing global health. We have a newsletter about that, which you can subscribe to. And we have some publications. And a lot of the examples I've given and the things that I talked about are in the publication to your left, which is Pragmatic Approaches to Decolonizing Global Health in Africa, which we published and is available, freely available on our website. But we also have an article that is published in the British Medical Journal on Global Health on the issue of decolonizing global health. And within this particular pragmatic approaches guideline that we've developed, again, we sort of lay out some of these manifestations of coloniality, and what we recommend are pragmatic ways to decolonize. And we address all the different constituencies, not just the two that I mentioned. For example, academic and training institutions, funders. We talk about scientific journals and publishers. We talk about the media, and maybe this is something that might interest you. So maybe I'll dwell on some of the things we recommend. It's much longer than this in the document, but these are just a few examples. And we say one of the common manifestations of coloniality is that, a lot of these international media houses, they publish global health headlines that are disrespectful and sometimes even outright racist, And so one way they could decolonize is to appoint diversity, equity, and inclusion champions within their institutions, set targets for diversifying their workforce and training their workforce in implicit bias and cultural awareness. If someone is trained and if it's an effective training, there's no way you're going to take a monkeypox picture from Black people or from Africans for an outbreak in Europe. That's absolute madness. Right? There's no way you're going to draw Omicron and paint it brown because it was detected, not discovered, not originated, because it was detected in South Africa, which, by the way, has a significant amount of white people as well. So why did you have to shade your cartoon with brown people, right? And so in summary, look, why I even gave that disclaimer at the beginning is that there's actually a dichotomy now. There are almost like two warring camps, let me put it that way, and you might not be aware of this, but in the academic space, there are two camps, really those that are calling for more theoretical approaches, more conceptual thinking about decolonizing global health. And then there are those of us who are more interested in action. We are not scholars, we are not academics in this issue, at least. So we want to see action, right? So there's this almost two camps. And of course, we have critics, right? And these are some of the things our critics have said, that we are just jumping on the bandwagon of decolonizing aid, that pragmatic and practical approaches that we are proposing are superficial, right? They don't address the root causes. And one of the words you're seeing here was actually a message somebody sent to me, a researcher in Germany sent to my inbox in Twitter after I published that paper on decolonizing global health, Where Are the Southern Voices? And she says that what we are doing is we are undermining science and we are creating an unhelpful antagonism between global North and global South researchers. And look, I mean, I always try to give this caveat that some of the best working relationships I've had are with people in the global north. So the intent of this whole movement is not to create enmity, right, between people in the global north, global health practitioners in the global north, or those in the global south. Is for us to surface some of these harmful practices and let's have a conversation about it, right? If we don't talk about it, things are going to continue. Business is going to continue as usual. We are not trying to create enemies. We are not trying to demonize any particular group. We are not trying to paint an entire group with one brush, but we have to just recognize that these are conversations that need to be had, right? And I like what one of our colleagues based in Canada, she's from Asia originally, but based in Canada, what she says about this false dichotomy. And she says, this is a false dichotomy between immediate practical action and addressing root causes. And she said, I'll compare this to a bucket. When water is flowing out of a hole in a bucket, of course, it is pragmatic and necessary to repair the hole, but we also need to turn off the tap. So we totally agree that, of course, if we can tackle the root causes of these manifestations of coloniality in global health by switching off the tap, that would be the ideal situation. But in the meantime, knowing that, tackling structural issues takes time. Think about gender equality. Look at how long it's taking us. Think about racial equality. Tackling the root causes of these power asymmetries and imbalances, it takes decades, it takes generations, right? So should we just fold our hands while we wait for the tap, hopefully to be turned off? Of course not. And so that's why those of us on the pragmatic side are the ones trying to patch the holes in the leaking bucket by some of the recommendations that we are making. And what are we risking? Like I said, there's microaggression. Somebody, I've received some funny inboxes, talking about what we do. When we started the global health decolonization movement in Africa, there were several of us. Some dropped out. They got afraid about their jobs. I don't have that fear because the organization that I work for, my day job, they encourage conversations about decolonization. So, even supporting some research on it. So I personally don't have that fear of job security issues, right? But many others don't necessarily have that, should I say, confidence that if they speak openly about decolonization, that there won't be some kind of retaliation. So that is the end of my presentation, and I am happy to take questions and make some attempted answers. Over to you, John.
Wow, thank you very much, Dr. Oti. Clearly, a lot of things in there that somebody needs to speak about, some conversation there that really needs to be taken place, just so that everyone understands the point, this point of view. Colonial medicine is indeed an area that seems untapped, and we are glad that you are here with us. And I think you will be available all through. I know you're based in Nairobi, and I'm sure some of the people here may want to take this conversation forward and just speak about, at Measure, we have spoken about vaccines and availability and hoarding and some of those things. And maybe one or two of us may want to put all this into, the context about the colonization of medicine, as you put it. I'm sure there are issues that will come up, even as our members here may want to take up some of those things. We are at 86 members currently on call, and that is a big number, and others are still coming in. We said you tell us your name, your country, your organization, and probably an email address. You never know. Someone may want to engage you on something. So if you haven't, please feel free to introduce yourself. Also, remember to use your name, your official names as you come in. I think I saw one Oppo. So remember to use your official names so that you can be properly, engaged as we move on. Ladies and gentlemen, at this point, we are not doing badly with time. We have recovered some of the minutes that we lost and even more, allow me to bring back again our captain, who will make a few remarks again, even as we prepare for the next session. Again, if you're with us.
Yeah, thank you. Thank you very much, John. Thank you, Lena. Thanks, Alice. Thanks, Bozo. And also thanks, Oti, for, you've made us start thinking about why the Fifth African Conference of Science Journalists. One thing that I usually say is that it is no longer business as usual. As journalists, we must now pinch ourselves. We must now start challenging ourselves and move forward the African science story. And so what is then the African science story? And the African science story cannot operate on its own. It must operate within an environment. And that environment basically means that we must embrace the issue of working, across the borders. And so thinking globally is the only way that we can ensure that we achieve this. And so I just want to, open the forum for questions from the first person who spoke, all the way from Bozo to Alice to Lena. And I want to thank you all, because I think this is a group of very kind people. I know Hugh, for example, woke up at 1:30 a.m. In Montreal to ensure that we were on. I know that people woke up very, very early to leave so many other things that they would have done. But then for this week, I just call on you to reflect on, what is my role as a science journalist? Have I moved the needle? What have I done since the year began? Am I just that journalist who attends meetings? Am I that journalist who attends meetings, get sources, and follow on those sources, and write stories that make a difference in the life of my neighbor? Am I that journalist, who is growing? Am I growing as a science journalist? Because if we are not going to grow as science journalists in Africa, then basically what we are saying is that we are not having an impact. And impacts would come from the kinds of philosophies that the likes of Samuel talk about. For those who are not very much conversant with Oti, Oti has always spoken in our conferences. And Oti also works for IDRC. He did not come here in his capacity as an employee of IDRC, but he's a guy who embraces a lot of networks. It's only in Africa where we still think that networks are a burden. Lena will tell you over there, she has been a journalist for over 40 years, and 30 years of that time she has spent doing nothing but agricultural reporting and editing. And so are we those journalists that would one day, 40 years down the line, talk about that big footprint that we left in our own countries? So I'm just asking these questions because we need to reflect on, why are we attending this conference? This conference, around 300 people, actually 350 people have registered. I am sure that the 350 people will register, will attend in one way or another, during various sessions, because I know some people are just interested in today because it is a health day. Tomorrow, I think, is agriculture, and then we get into environment and issues of climate change. And so let us reflect, let us sit back and relax and be easy and think about, what is the story that I want to tell? Certainly this conference is too big for you to attend for 4 days and you don't have a story to tell. You can do Q&A on some of the speakers. There are lots and lots of opportunities. And at this point, I also want to announce that because of the good work that you journalists do in Africa, Mesha is going to ensure that we take at least 5 or 6 journalists to the COP27.
Hello, good morning, Daniel.
Yes, Emma.
Hello?
Emma, you have something to say?
Good morning, Daniel.
Good morning. Yes, so basically what we are saying is that we are going to have a travel grant to COP27, and it's going to be very competitive. We are going to make sure that each region of Africa gets one of those slots to go to COP27. For those of you who will not be lucky enough to travel, we'll ensure that we support you financially to do the reporting from your own, in your own country. You could follow online, you could follow in whichever way, but do stories on climate change, and especially on COP27 that is coming up in the month of November. We have lots and lots of opportunities that we need to think about. And so it is your turn. It is your time. John, I want to thank Lena in a very special way. IFAG is that organization that has been supporting Measure in a way that I'm not so sure that they support others. It's just our pride that they have given us a special place to work with us as an African outfit. We are only saying that perhaps, Lena, when you sit down with your board again, I think we need more representation from Africa in whichever way, in the work that IFAD does, and even in the board that of IFAD, so that we can also influence. I think Oti has pointed out to the fact that sitting in a board makes a lot of difference, because these voices are never heard unless you have a representative in a board as good and as big as that of International Federation of Agricultural Journalists. And so, Lena, we thank you again for coming and for gracing and making that we have ensured that the conference is high profile. And to the rest of the team, I wish you all the best, even as we go into other other presentations. But for now, I'm back to offer you an opportunity to ask questions. And I will send the first question to Oti. Oti, listening to you, are you just a bitter person who is out there to settle scores with people who have denied you opportunities before? Or what is it that drives you to talk about decolonization of issues of health globally, that is? And I would also want you to give us some few examples of initiatives that you think have overcome decolonization of issues of health in Africa. Because I think that it is not all gloom and doom. I think there are also some other things that you can pick on and that we as journalists need to be aware of. Over to you, John, to take us through the question and answer session with Oti and the rest of the team.
All right, thank you again. I'm not sure we want to, do we take each question as it comes and it's responded to, or we take a few and go? If you want to, if you have a question, I suggest you just switch on your mic and ask so that we go, or you can type it on the chat box. Then we can be able to read it out so that somebody responds. Meanwhile, Oti, you can respond to Agan.
No, great questions. And of course, I'm not a bitter person at all. I think, there are increasing voices of dissent, let me put it that way. Did not begin with me. In fact, a lot of the initial conversations that are being had about decolonization originated, ironically, in institutions in the global north, in Harvard, in Duke University, in the London School of Hygiene and Tropical Medicine, where academics, researchers who are either what we call minoritized or who are originally from low and middle income countries began to question, especially the curricula, of some of the, schools of public health, the global health programs, and how these programs and this curricula fail to acknowledge the origins of global health and the colonial past of global health. So a lot of those conversations, there are more and more people who are, joining these conversations. And I think where we come in as the global health decolonization movement is really to serve as a platform to unify African voices, right? And that's why we talk about coordinated advocacy, to serve as a platform for more people, because like I said, the origins of the conversations have been in the global north. So we felt that there's not sufficient representation of those of us practicing global health in the global south. And so we need to create a platform where more people can come and speak about their experiences, but not in a destructive manner. And that's why we did not, one of our flagship initiatives was to develop guidelines to say, here are what we feel are some ways of doing things better, right? So it's not just about condemnation. We are definitely not condemning people. It's about raising these the challenges with some of these power imbalances, but also providing what we feel are solutions. Will those solutions work? We don't know. These are quite subjective. These are our opinions of what may work if things are done differently. In terms of some of the initiatives, again, this conversation on decolonization, especially as it relates to global health, is relatively new. But there are some practices, even historically, in global health that have been helpful in sort of shifting some of these power imbalances. Some organizations, for example, have written it into their code or into their policies that if they're working in a specific area, the lead applicant, let's say for a funder, the lead applicant must come from that particular region or sub-region, right? And that person would have the lead. And they have policies that ensure that, the lead applicant is not just a front for someone else who's trying to take advantage of that. Funding remains a big issue, but it's not just an issue for even organizations in the global South. But historically, those in the global South have been disadvantaged. And so some funders, some of you might have heard the likes of what McKinsey Scott did, and how she identified quite a number of organizations in the global South and gave them more or less unrestricted funding, and that gives them power to now decide what their own focus will be, what their own agenda will be, rather than the very top-down approach that we tend to have in global health, where the funder sort of sets the parameters and you have to more or less align yourself with that. But when you have this kinds of unrestricted funding, it signals a belief in your institution that you are capable of doing this work. You're capable of recognizing what the local needs are, and you're capable of responding to those needs, right? And so that can help, shift some of the power imbalances. Back to you, John.
Thank you, Oti. I can see there's a question on the chat box from Japheth Macau, and he asks, Oti, is it the colonial mindset we Africa tend to show the international community that we can't do without them, which makes you ban in quotes like this? According to you, where do you see Africa in the next 5 years in terms of dependency?
Burn is a hard word. Of course, I'm passionate about decolonization. But again, I want to reiterate that this is not about creating a divide. Movement is not about creating enmity between us and our colleagues in the global North. This is about finding a constructive way to ensure that these power asymmetries are surfaced and that they are tackled. But one thing I didn't say in my presentation, and maybe I should have gotten to that, is that there is a role to play. We also have a responsibility as people in the global South. Some of the behaviors we've seen on the other side from our global North is actually in reaction to some of our own antecedents, so to say, in the global North. There are institutions here that have mismanaged funds. We know about that, for example, that have engaged in unethical practices, right? And so when you see, the colleagues in the global North, the institutions in the global North being very rigid, in how they handle, being almost micromanaging how, resources are distributed, there is some smoke, what they say, there's no smoke without fire. There is some antecedents for why some of these reactions and some of these behaviors are happening. So we have a responsibility as global health practitioners in the global South to have integrity, to do things the right way, to be accountable, to be transparent. We have a responsibility that we can't shy away. But also our governments have a responsibility to invest in international development, in our own development, to invest in global health, for example. We all know about the Abuja Declaration and the 15% that our own governments, nobody put a gun to their heads, our own ministers agreed to committing 15% of their annual budgets to health. And that has not materialized for majority of the countries in Africa. And so this dependency on international funding is enabled by this lack of commitment from our own funders. So we also are enablers of these power imbalances in a sense. And so our governments, our policymakers also need to do better. Back to you, John.
Yeah, thank you. And I think your last point really responds to the question from Bozo, who is asking if Africa is really able to get out of this dependence on matters global health. Excuse me. But there is another.
Sorry, John. If I may add, and look, local philanthropy. I don't know what is happening with that. We have billionaires, we have very wealthy people, and we are just not seeing, enough local philanthropy in Africa and in the developing world. And this is something that also needs to change. Yes, we have the Dangote foundations, the Tony Elumelu, the Mo Ibrahims. We have a few of them, but comparatively, our wealthy people are not doing sufficiently enough to invest in our own development, right? And so this is also something that we need to, as journalists, I would call on you to put their feet to the fire, ask and hold them accountable. What are you doing with the money? Why are you sitting on it? Open these foundations up, right? Regardless of the original sources, and I know this might be controversial, but I don't want to mention names, but there are some foundations that the origins, even global foundations, of how they made let's say the people who the foundation is named after, how they made money might not necessarily be above board. And I'm not suggesting, for example, we use mafia money, I don't know, or, but the most important thing I believe is that if that charity or foundation is legally registered, right, and the government of in that particular context, in that particular region, allows it to be registered, then at least, hopefully, it's because they believe that, that foundation will be above board, right? And so we need to hold these people accountable. We need to call on our billionaires, our rich people to also begin to invest beyond this tokenistic CSR things that we see. There's just too much CSR that, is not really looking at the long term, right? And this is something I think needs to change.
Yeah, thank you. I mean, if Bill and Melinda Gates can sit as husband and wife and put in money for some of these things, what is so difficult from our own Bill and Melinda Gates in Africa? Because it's true that we have them. So that's for us here at Mesha and really across everyone on this call who has an opportunity to write articles that we may want to begin asking these questions. But Joseph Othforth is asking on the chat box if that are you alone on this matter, or do you have other people who think the same way? And most importantly, do we have research institutions in Africa willing to support this whole idea of decolonization of global health? Oti.
Excellent question. And no, of course, I'm not a lone ranger. In the global health decolonization movement, in Africa, we have a panel of movers. I'm just one of a number of people who sit in that panel. We call it panel of movers. I'm one of a number of people that sit there. And I mean, if you've been following the space closely, there's quite a number of people in the global South who are beginning to speak up. But again, I think that was the whole idea of creating this platform, so that we are more coordinated. Because as it stands, you have the voices are isolated. Let me put it that way, right? You have these pockets of people here and there across the continent, South Africa, Nigeria, Kenya, Ghana, the usual suspects, who are speaking up about decolonization, but not in a coordinated manner, not in a coordinated fashion. And so that's what our platform is all about. institutionally, I think that's where it becomes trickier. Because like I said, a lot of the institutions in the Global South are still heavily, heavily dependent on, this, the funding architecture, let me put it that way, the funding landscape, the international funding landscape. And so it will take some time before you would find an institution that will say, you know what, explicitly, we are going to back this movement on decolonization and we are going to speak up about it. But having said that, there are institutions that in their own way are pushing back. Some of them are, they are pushing back when these relationships begin to show imbalances. They say, no, we're not going to accept this way of working. We're not going to accept this budget, for example, that looks skewed. We insist on this, having an agreement about authorship, for example, on articles, and agreeing on it before we even launch the project, for example. So, of course, many organizations, a number of organizations are beginning to push back in their own way, but I'm yet to see, an established institution, coming up and speaking out very vocally, right? At an institutional capacity. You might have maybe the CEO, the executive director, making comments. For example, we've seen some leaders, really criticize what is going on with the reporting of monkeypox. For example, I know some public health leaders in Africa have been very, very vocal about that misrepresentation in the monkeypox outbreak reporting. But we need more coordination and we need more institutional players to come to the table, I think, for this movement to really gain traction.
Thank you. I see Lorraine is also lamenting on how dependent we are on donor funding. I don't know if there is anyone else with a question. We have had Dr. Oti, we've had Lena, we've had Bozo. Is there any question directed to any of them before we probably wrap this up and move to the next session of this morning's presentations? Anyone else, so that we don't lock you out? If there is none, again.
Right. So thank you, John. Thank you, Sam. Sam, I would really want you to stay for the next 1 hour at your own pleasure. Time permitting on your side, you can put off your video and join us in our next Science Cafe. So ladies and gentlemen, as I said, sit back, relax, and think about the next session. You've heard of the radicalism of the nice words from Oti, what we think ourselves in terms of global health. But now let's bring this down to real research and real experiences that are happening in the world of HIV research and treatment and that kind of stuff, prevention, name it. And so I have a team of 3 people who will be talking about issues of HIV. And the first speaker would be a lady called Patricia. So Patricia, I'm just testing your mic. Can you just say hello? I want to be sure that your mic is on.
Hello.
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 Yes, Patricia, say that. Great. That is great. I think we can hear you very well. And then after Patricia, there will be Dr. Momanyi. Dr. Momanyi, please test your mic wherever you are.
Good morning.
Morning, Dr. Momanyi. Can you say good morning again?
Good morning again.
Okay, great. We can hear you very well. And then we have Jackie Wamboy. Jackie, can you please test your mic? I'm just testing your mics.
Hello.
All right. So Jackie, thank you very, very much. I know that you're taking this call almost half a world away, but we are here in the capital city of Nairobi and other capital cities in Africa. I'm very happy. Let me single out 2 people that I'm also very happy to see. Not that I'm not happy to see all of you, but I'm very happy to see a very old friend of mine called Razia. Razia from Dar es Salaam. Razia, would you want to say hello to this team?
Hi, hello everyone. Good to be here.
That voice is still the same voice of Razia 20 years down the line. Thank you very much, Razia. And say hi to the people in that great city of Dar es Salaam. I'm also happy to see Felix, Felix Mwakiembe, all the way from Mbeya.
Hello, comrades. Happy to be with you here today.
Yes, I have a friend, I think, from Ivory Coast. There's a friend of mine from Ivory Coast, all the way from Ivory Coast. I know the French down there. And Engela from South Africa. Aima, you are trying, Amable, you are trying to say something. If you want something, please just put it on the chat and I'll get directly back to you, Aima from Rwanda. So Africa is represented here, Patricia. So this is a team of African science journalists who want to listen to what we do in the Science Cafes, and particularly on what is happening in the world of HIV and AIDS. And so to everyone, you are very special to us, to all of us. So please feel special, feel wanted, and stay home. Now, over to you, Patricia. Patricia, please tell us something about yourself. I did not manage to get your bio in good time, but just tell us who you are. Tell us a little bit about LVCT and then get into your presentation. And good luck as you speak to us.
Good morning, everyone. My name is Patricia Jekona. I work with LVCT Health, and I'm a senior technical advisor for policy and partnerships, and also the project manager for Mosaic. And I'll be delving a bit into Mosaic because it's relevant for the presentation this morning. I'm currently doing my studies in public health, and I've been involved in the space of HIV prevention for the past 10 years, since the introduction of oral PrEP, and currently working on the introduction of the ring and also Kabele as and when it is approved in the country. So I'm happy to be here. And LVCT Health is a local Kenyan organization that has been working in the space of HIV prevention, sexual reproductive health, gender-based violence, and mental health. And we are quite involved actively within the HIV space in Kenya, including care and treatment, providing technical support, undertaking research, and also piloting innovations within the HIV space. So I think I would go ahead and project. Is that okay?
Oh yes, that's okay. And even as you try to project, I just want to tell all my colleagues on this call that this is not a session where we just listen, but please feel free to raise your hand to get clarification, just in case Patricia says something that is vague. We will not wait for the question time. So this is a very interactive session. Please make it interactive. Over to you, Patricia.
Great, thank you so much for mentioning that, and thank you for inviting me to do this presentation. So I will just get into the content and trying to put the HIV situation in the context of Kenya. So in a few years back, we signed the HIV prevention targets, and we committed to reducing new HIV infections up to below 22,000 by 2020. But as of 2020, we reported 33,000, so we were off track. We still have 15 to 24-year-olds contributing 41% of all new infections in the country, with adolescent girls and young women contributing up to 2/3. And Kenya implements the combination prevention interventions. Here we mean that there are biomedical interventions, and other interventions address the behavior of the people, and also the structural that looks at other supporting structures that would expose someone to be vulnerable to HIV. So we have a combined approach to the HIV response. Key populations, as we call them within programming, these are men who have sex with men, female sex workers, people who inject drugs, and the transgender persons continue to be disproportionately affected by HIV. We have experienced shortages in some of the biomedical products like condoms, HIV test kits, and this often becomes a barrier to prevention. We equally have limited funding in HIV prevention. That is both from the donor perspective, the landscape is really changing, and even in terms of the national allocation to prevention. And I put that background so that we understand what is the need for new HIV prevention products. So just to be aware that the available products have not actually slowed down the epidemic amongst women. We still have women contributing the highest in the HIV infections, up to about 67%. There's need for more discrete options for women. And also, no one product will solve the HIV epidemic. And lastly, women need multiple prevention products that make sense for their lives. So a number of vulnerabilities that women face, and I really focus on women here, because this is the population that's still lagging behind when it comes to preventing HIV.
But Patricia,
yes.
Are these African women or Kenyan women only?
African women.
Okay.
Yes, African women. So this applies within the African context. A lot of our countries have more than 50% of new infections coming from adolescent girls and young women. And so a lot of effort now is being put just to focus on the women to see how we can reduce the new infections. So I'll delve directly into the new products that are upcoming. So a lot of the African countries already approved oral PrEP, which is taken daily. And amongst the men, now there's also the event-driven PrEP, which is taken to reduce the chances of getting infected with HIV. We recently had the dapivirine ring, which was developed by the International Partnership for Microbicides. And different bodies gave approval. I will get to it, including Kenya. So the dapivirine vaginal ring is a flexible silicone ring which slowly releases an antiretroviral that is known as dapivirine, and it is released locally in the vagina with minimal exposure elsewhere in the body. So the concentration of the dapivirine is found within the vagina. The users are able to insert without much support from a provider, or if they will need a healthcare provider, that can also be done. It is the first long-acting HIV prevention tool. It is kept in place for a month before it is replaced with a new ring. It is very discreet and does not interfere with sex. Discreetness here is important because we have seen women not adhering to for example, oral PrEP, because they are afraid if they are found out, their partner sometimes thinks that they're already HIV positive, or they're told that they don't trust their partner. We've had cases of people being beaten up because they were taking oral PrEP and they were found. So a lot of challenges with some of the other products. Condoms, for example, a woman has to negotiate with their sexual partner to be able to use it. So the dapivirine ring also has mild side effects like mild vaginal discharge and itching, which normally goes away within a week or two. So why do we have the dapivirine ring? In terms of its profile, in all the studies, there were no safety concerns. It was shown to reduce HIV risk in clinical trials. It is easy to use, it is long-acting, and it is private or discreet. So the reasons for its development is that adolescent girls and young women, particularly young women, are disproportionately affected by HIV in sub-Saharan Africa. Available HIV prevention products have not stopped the epidemic. People want HIV prevention options that are discreet, that are long-acting, so they don't really have to keep remembering when to take when to use the product. And that they can also be able to use even without the cooperation of their sexual partner. Lessons from contraception have also shown that increased options lead to increased uptake, So adding a new tool into the HIV package can also help increase uptake of HIV prevention methods. And lastly, that a product with a few side effects can be easily provided both within and outside the health facility that may reduce barriers to delivery and uptake. A brief on what has been done so far for the ring. So we had some efficacy studies that were looking into efficacy in phase 3 of the trials. 4,588 participants were enrolled between the ages of 18 to 45 in Malawi, South Africa, Zimbabwe, and Uganda. The ring reduced the likelihood of acquiring HIV by approximately 30% overall, and it was well tolerated. The HIV risk reduction was likely greater among participants who used the ring at least some of the time. So the overall risk was reduced by 40% amongst the participants over 21 years, and no reduction amongst participants under 21. And this one, demonstrated that there was likely non-use of the ring. So there are currently other studies that are going on just to look into the efficacy of the ring amongst the 18 years and below. So moving into the open label extension studies that are normally conducted after the clinical trials, 2,790 participants from the former studies in the 4 countries were enrolled. Taken together, modeling data from the 2 open label studies suggested a likelihood of HIV acquisition amongst participants was reduced by 50% compared to the 30%. So the results were limited due to the lack of a placebo comparison group, but indicate an encouraging trend. So what this shows is that the more somebody uses, one is that when people know what they're using and they use it consistently and well, then it increases the level of them being protected from getting an infection. So there were these several studies that took place: the ASPIRE, the RING study, HOPE study, and DREAM. And I just want to point our attention to the DREAM open label extension study that was undertaken, and it estimated reduction in risk of HIV acquisition at 63% overall. So it shows us that the more people are able to use it and use it well, then the higher the chances of being protected. So the ring got a positive scientific opinion from the European Medicines Agency. And the European Medicines Agency normally would approve even for products to be used outside of the European Union. So they said that it can be used to reduce HIV during receptive vaginal sex in combination with safe sex practices when oral PrEP is not used, cannot be used, or is not available. So the dapivirine ring would be the other option in places where the user is not able to use the ring, to use oral PrEP, maybe because of the side effects and other reasons, or where oral PrEP is not available. Then in November of 2020, we had WHO pre-qualification that indicates that the ring meets global standards for quality, for safety, and efficacy in reducing likelihood of HIV acquisition. January of 2021, a conditional recommendation by WHO was issued. So WHO recommended the ring as an additional choice for cisgender women who are at substantial risk of HIV acquisition and cannot or choose not to use oral PrEP as part of the combination prevention approaches. Cisgender women are the women who biologically are born female, and they also play feminine roles within the society. On March of 2021, WHO issued clinical guidelines, including the recommendation of the ring. So that was issued in March of 2021. So the next slide, I'm just going to talk about the United States Food and Drug Administration, that's the FDA. And in March of 2021, IPM had already put in a request for a new drug application for the ring. And what happened is that by the end of 2021, that is in December, IPM decided to voluntarily withdraw the new drug application from FDA. And this is because feedback indicated that the current data are unlikely to support the US approval given the context of current HIV prevention landscape in the United States. So there was a lot of panic when this came out, but we also got to really understand that our governments, a lot of the governments within the sub-Saharan African region would rely on WHO's opinion. So the US FDA normally approves products for use in the US, and they do not approve drugs for use outside of the US. So just to help us understand is that the US, for example, in 2018, they had a total of 36,400 new cases of HIV, and of those, 6,700 were amongst women. But when we look at the East and the Southern Africa, in 2018, same year, we had more than 800,000 new cases of HIV and a total of 208,000 occurring amongst young women aged 15 to 24. So you realize that the depth of this epidemic is largely affecting sub-Saharan Africa compared to the United States. And so it made total sense if the FDA actually saw that the ring would not really, add so much, probably have so much impact in reducing the new HIV cases in the US. But we know that for East and Southern Africa, we really need an additional product to bring down the new HIV infections. So just some key points to remember is that users find that the ring is acceptable, is an acceptable PrEP method for HIV prevention. There were a number of acceptability studies that were done in the countries where the ring trials took place. And then when used, the ring reduces likelihood of HIV acquisition during receptive vaginal sex by about 50%. But remember, we said when people are able to use it well, put it in place without having to remove it often, then these efficacy levels have shown to actually increase. Use of the ring in settings with a high incidence amongst girls and women creates choice for people who do not, cannot, or are unable to use oral PrEP. The WHO, through pre-qualification and recommendation of the ring, indicates that the ring is safe and effective. And we currently have countries in Africa that have already approved the ring. So Zimbabwe did it first, then there was Kenya, then SAPRA of South Africa. And this morning I was also told Uganda is part of this list. So we have about 4 countries that have already approved the ring. And I know for our national government, they're yet to do like an official announcement of this. And it's because of the current discussions that are going on also with the funders to see how the ring can be made available in the country. So I will transition from the ring and take us to another potential new product that is known as the long-acting injectable cabotegravir. And it is an anti.
So Patricia.
Okay. So maybe we take questions.
Yes, on the ring and
on the ring.
Yeah. So one of the I'll just read the questions, but if somebody wants to voice their question, please feel free. This is a conference where we talk ourselves. Let it not be somebody else talking on your behalf like me now. Anybody who wants to voice their question? Or you can use my voice if you want. My voice is available. Okay. Now, Anne Mikia asks that where are we in terms of Kenya? Is the ring available in the country? This Anne is from Kenya. And then, so Patricia, maybe you'll be writing somewhere. And then there's this gentleman who asks, can this ring be used by gay men? Okay. And then the other one is, maybe we have a higher number of women being affected by HIV because men do not do much testing, you know. Not so many men are brave enough to go for the tests. And is that narrative not changing? And then somebody else is saying, you're giving us data from the US. Can we also get data from our local countries, e.g. Uganda, Kenya, Tanzania, you know, that kind of thing. And then Julius Odeke, this gentleman comes from Uganda. And his question is, and he doesn't like noise. So his question is this. Doesn't the ring make noise? In other words, what are the effects of using the ring? Those are many questions for you, Madam Patricia. Please take them on. And also repeat the countries that have approved the ring. I think you talked about there are 4, just repeat them.
All right. So I'll start with that last one because it's still the slide on the screen. The countries that have improved is Zimbabwe, Kenya, South Africa, and Uganda. So if I could go to the first question in terms of where is Kenya with the implementation of the ring. So this was actually going to come much later in my presentation, but I can allude to what is coming. So far, and I'm glad to see Dr. Mwanyi on this call, we have gone ahead to actually include the ring in our current guidelines. And I'll be talking about an introduction study that is coming up in Kenya to bring the ring on board. And also other negotiations are ongoing with other donors to also see how we can bring the ring to scale, to move it just from a few pilot sites to scale. So I'll be talking about that later, but at the moment we do not have the ring in the country. So can this ring be used by gay men? The answer is no. The ring is only used by the women, girls and women, because it protects acquisition of HIV at the vagina. So one must actually be having vaginal sex for them to be able to use the ring to prevent or to reduce the chances of getting infected. So because of where the ring is placed, so this cannot be used by gay men. The other question is on uptake of HIV testing amongst men. I think a lot of effort has been put to increase uptake of testing amongst men. But also we remember that for women, it's also our biological makeup. We are largely receivers. So the chances of getting infected is much higher in women compared to men. But then also we also have new products like the HIV self-test kits that were brought on board to actually improve or increase HIV testing uptake amongst men. So more efforts need to be, put in place. And every other time we keep saying the men have the answer to uptake of HIV services. So they need to just speak up and we see how best can we improve the uptake of HIV services. Data in terms of local countries, I think in my presentation, I focused on Kenya. I focused on sub-Saharan Africa. I didn't go into specific countries, but there is definitely data for around HIV in our various countries. And the studies that I presented for the ring are studies that were done here in Africa. So all the results that I've shared are results from Africa. Doesn't the ring make noise? No, the ring does not make noise. It is silicone. So once it is put in place, or at least the voices of the men from the studies also said, a lot of the men said they couldn't feel the ring during sex. So that's a good thing. They also said the ring did not interfere with their sexual, like their sexual activities with their partners. So that's why we are able to just say that it is discreet. One can be able to use it and it does not interfere with their sexual activities. So again, I think I have responded to all of them. Is there any other?
Yes, in terms of the countries, you said Zimbabwe, Kenya, but you also, and South Africa, but then you also said Uganda. Yeah, you heard of that this morning. My only worry is that why should Kenya go ahead to approve it, yet it is still not there? That is one. Why do you approve a product that is not yet available? And then the other issue that I have is that if I would walk into Zimbabwe and then I carry maybe 1,000 pieces of the vaginal ring, would somebody stop me at the airport that, hey, where are you taking these gadgets?
So why approve products? So the product approval processes are done by regulatory bodies. So for example, in Kenya, we have the Pharmacy and Poisons Board that does these approval processes. So a product must be approved first in country before it is made available. Otherwise, we would have no basis of bringing a product. So those are the processes of introduction of new products. The application has to be done for the medical products through the Pharmacy and Poisons Board, then they are approved, and then now the implementing arm of government looks into bringing an already approved product into the country. So also just to mention that all these 4 countries I have put here as the ones who have approved the ring, none of them has the ring in the country at the moment. So all these 4 countries are part of a bigger project that I'm going to talk about. It's known as Mosaic, that is going to bring the ring into the countries within specific pilot sites. And then similarly with what we did for oral prep, we had oral prep into the country after the approval, then did some demonstration studies, and then got prep into the bigger markets. So these products do follow, like a particular process before they are made available. Again, you have muted.
Yeah, somebody is asking what is the percentage in terms of prevention that the ring has been known for, and then what about how much would it cost?
All right. So the efficacy, as I mentioned earlier, within the clinical trials, there was a report of about 30% efficacy. And then in the open label studies, this moved to about 50% on average. But we also know one of the studies got up to 63%. So the efficacy levels seem to show us that as people use it and use it correctly, put it in place without having to constantly remove the ring, then we have higher efficacy in the people who use it and use it well. In terms of the cost, so in all these countries, the ring will be offered in the public sector for free, if I can say that, but we always know there's somebody else who pays for it. That's the donor, or governments can be able to pay for the ring. So at the moment, on average, the price of the ring is about $12. But they will be brought into the country having been purchased by the donors, so they'll be made available in the public health facilities within the pilots for free. I hope that helps.
Right, so you can continue. You only have 20 minutes to do everything else that you want to do today.
Great, hello. Thank you very much.
May I interject a bit?
Yes.
Yeah, I had asked previously a question, but I think again.
Your name, please.
My name is Scovian Lillian.
Right, go ahead, Scovian. From which country?
From Kenya.
Go ahead.
Yeah, so I had asked Patricia, she had mentioned the 67 figure in the beginning of her presentation. So I had asked to know how recent is that figure?
What 67?
There is a figure you had mentioned, the 67% of infections in sub-Saharan Africa for women.
For women, this is 2018. I think I had put it, no. So I'm wondering whether it's so at the beginning of the presentation, I said the percentage of infections amongst women. Women contribution of the new infections amongst women in Kenya specifically is actually about 67%. That should be our data for 2020.
I think that what you talked about is on the slide that is currently showing, where you talked about, you gave statistics from the US, where 2018 there were 36,400 new cases. And of those 6,700 who are 18% were among women. I don't see any other 67% anywhere. In your presentation. So again, let us clarify those figures. Let us be slow in reporting figures, but let us ensure that we actually confirm those figures. So I think the other question is how recent. I think recent is also put here. In March 2021, you've put that. In 2018, you've talked about the 18% among women and that kind of stuff. So I see that quite articulated here in this particular slide. I hope everyone is seeing this slide. I did not hear of any 67% elsewhere, but maybe it is there. If it's there, I'm going to look at that presentation again and share with you. So Patricia, please continue.
All right, thank you. Thank you again. So I'll transition into the other new product, the long-acting injectable cabotegravir. Largely, a lot of people call it Kabele. It's an antiretroviral drug formulated to be administered once every 2 months as an injectable form of PrEP. So this is an injectable. So somebody gets their jab every 2 months. Its efficacy data, especially from the phase 2 of the clinical trials, showed that one, it is safe, it is well tolerated, and it is effective. And amongst the men who have sex with men and transgender women, it showed a reduction in infections by 66%. Amongst the cisgender women, it went up to 89%. And as of December 2021, Kabele was additionally approved by the US FDA for use as a prevention option. It also got a positive opinion from WHO, and we are currently waiting for the official guidelines from WHO. The developer, that is Viv Healthcare, have also submitted a new product application to the Kenya Pharmacy and Poisons Board for approval. So we are waiting to hear from the Pharmacy and Poisons Board whether cabotegravir long-acting can also be added into the HIV prevention basket for Kenya. In terms of the side effects, these are some of the side effects. So the jab is given, we call it at the, how do we call it? So the jab is given on the buttocks, and so some of the side effects are the injection site reactions. So there could be some pain, some tenderness, some hard lumps, as any other injection. Some people experience diarrhea, headache, fever, fatigue, sleep disorders, nausea, dizziness, abdominal pains, vomiting, muscle pains, decreased appetite, drowsiness, back pains. And I would say these side effects do not apply to everyone. And just like any other drug, some people experience the side effects, others do not. And some will experience a bit of this, but not like all of them. So I do not want to talk much about the cabotegravir long-acting, because once the approval comes in, then we are able to provide more information on the direction that Kenya takes with the cabotegravir long-acting. And in terms of just some of the other products that are in the pipeline, there's also another oral PrEP. There are two types. There's the FTAF that is currently going through efficacy trials in cisgender women. There's also the islatravir, that is a monthly oral PrEP. and it's in trial phase right now amongst the MSM, the transgender and the cisgender women. Then there is Kabele, we've spoken about it. It's still within the pipeline in terms of approval processes. There is lenacapavir. Lenacapavir is also an injectable, and efficacy trials are ongoing for it as a 6-monthly injectable. There is the dual prevention pill, which is, we have a contraceptive added to the antiretroviral to prevent both HIV infection and also pregnancy. So these ones are still being tested. And where you see the big circles, those are the places where we are expecting to hear some approvals. And if you can look at the Kabele, we actually got FDA approval before 2022. So as more data is released, then some of these products are much nearer the market than we anticipate. So in terms of just the next steps, you'll allow me to cover these next steps and then you can ask questions. There is a new project that has been awarded by USAID. It's known as Mosaic. So Mosaic stands for Maximizing Options to Advance Informed Choice for HIV Prevention. And the vision is that after 5 years, women in sub-Saharan Africa will have access to multiple effective biomedical prevention options that meet their needs and their desires, and that the health system is enabled to support informed choice and effective use through policy, programming, differentiated service delivery. Currently, the countries that we are looking at include Eswatini, Lesotho, Kenya, Namibia, Nigeria, South Africa, Uganda, Zimbabwe, and Zambia. So, as I said, this project is PEPFAR funded. It's a 5-year project that ends in 2026. And the core partners are, we have FHI 360, we have LVCT Health in Kenya, is the manager in Kenya, VITS-RHI, the manager in South Africa, we have PZAT, the manager in Zimbabwe, we have AVAC and JAPIGO. The project is focused on research and research translation to support introduction and access to the new biomedical prevention products. Our huge focus is on women. We are working across multiple countries to support evidence-informed and user-centered product introduction. We are supporting a multi-product market with informed choice. So if these products will be introduced within the life of Mosaic, we will be supporting their introduction. We work very closely with the ministries of health, the USAID missions in the countries, implementing partner civil society, end users, providers, and other stakeholders, both local and global. And we are emphasizing on having informed choice, ensuring that all these interventions are country-led, there is intentionality, and also equitable co-leadership. So all these entities, we have forums where we engage the various stakeholders to ensure that their voices are heard. We have 5 strategic priority areas. We have user-centered approaches, so largely ensuring that there's gender integration and also meaningful youth engagement. We have product introduction research. So there's a study that we are currently working on the protocol, and we have involved various stakeholders to provide input into the protocol so that we are able to answer critical questions that countries want answered to inform implementation and scale up. Product introduction policies and programs. Again, here working very closely with the ministries of health. In Kenya specifically, we've been working with NASCO to ensure that our policies are revised, that we are already starting to think about what to do within the health system to make the systems ready for the new products. We have research utilization and knowledge management. The evidence that we churn out of these studies will be disseminated in real time through various channels and various entities, working with various stakeholders, because we want to ensure that this evidence is informing implementation. Then local partner capacity strengthening. We will be working with local organizations in the country and strengthening their role in introduction and scale up of new products. So within Mosaic, there is, as the study itself is known as Catalyst, and Catalyst stands for catalyzing access to new prevention products in Africa for adolescent girls and young women to stop HIV. So the goal is to assess the feasibility, acceptability, uptake, and patterns of use with the PrEP service delivery package, providing choice of oral PrEP, of the PrEP ring, and cab PrEP amongst women, and especially the adolescent girls and young women at PrEP delivery sites in Kenya, Lesotho, South Africa, Uganda, and Zimbabwe. The program design is that the study will implement an enhanced PrEP service delivery package that supports choice. And we are really focusing on choice because we want to ensure that the providers offer information that helps the end users to decide what works for them, what fits into their lifestyle. And in terms of the study design, we will be using prospective observational cohort and also mixed method process of evaluation. In the country, specifically for Kenya, we will be doing this in 3 counties in Kenya, that is Nairobi, Mombasa, and Kisumu. We will have 6 public health facilities, 2 per county. Our target are young women 18 years plus at the moment. We are still waiting for more data to tell us the efficacy and safety amongst the under 18s, and also for pregnant and breastfeeding people. Then the focus would be offering women the choice. The Catalyst will take a phased approach. So we will have a phase 1 where participants are offered with oral PrEP and the ring, and then transition into a phase 2 where participants are offered oral PrEP, ring, and Kabele. So that is it. Thank you very much. I will open it up for questions or any clarification that you may require.
Okay. Sorry. Thank you. Thank you, Patricia. I think we are still within time. My question is that, being a Tanzanian, my question is, why were we left out of Mosaic?
Okay. So I want to say that Tanzania was not left out of Mosaic. The countries I have put here are the countries that have already received, mission concurrence is like a go ahead, but we are waiting for other countries. So Tanzania is yet to get that mission concurrence, and also clarity from their Ministry of Health, whether they are taking on the ring.
The same could also apply to Ethiopia?
Yes.
Or the Ethiopian situation, they don't have people with HIV, so we don't need to intervene?
So I would say, like every other project, they're usually what we call priority. So priority, here we had priority countries based on their data, the new HIV infections, especially amongst girls and women. So that's what we looked at to be able to determine which countries would be a priority. Like if we were to make an investment decision, where would we put in the investment and still be able to get high impact in HIV prevention? So I would say these are like the top priority countries based on their numbers.
So Violet Otindo, our former chair, asks, hello, Patricia. My goodness, that thing has run away from me. Mekonnen is saying, I hope this is not discriminating Ethiopia. Or he's saying,
it's not.
He says, I'm joking. Now, Violet is asking, how far are we with multi-purpose but this word usually disturbs me. I don't know how to pronounce it. Is it purpose or purpose? Okay. How far are we with multi-purpose technologies? Any in the pipeline? How far?
So the multi-purpose, I will straight on just on the slide that I've put up. That's, for example, like the dual prevention pill, which is for both HIV prevention and pregnancy prevention as a multi-purpose tool. We anticipate to actually get some approval in 2020, towards end of 2023. So that's still something in the pipeline that we are waiting for.
Okay. Are the youth always involved in the various research?
Yes, they are. And I am happy to report that within Mosaic, as I said, one of our core values is intentionality. As late as, or as early as last week on Friday, we had a youth meeting to go through the Catalyst protocol to give us their ideas and also to give us any questions they would want to see answered. We have a global community advisory board for specifically young people, and we will also be having these advisory boards at country level, specifically for young people.
Okay, so I think that, thanks, Patricia. Is anyone in talks with the VIIV, the makers of the CAB?
The injectable?
Yeah, to bring prices down. At the moment, public prices seem out of reach for countries on the continent.
So I would say, as like any other product, including the ring, there's already a lot of advocacy that is ongoing to bring down the prices. But of course, we know there are many other determinants of the price. Remember, some of this pricing is being done without necessarily knowing what the demand is like. So there are various factors that come into play in setting the price. So there's already advocacy that is ongoing. And as these products are rolled out, what I'm aware of is that VIV, for example, plans to avail the injectables within the public health facilities in sub-Saharan Africa for free. And as we look at the demand and what people would want supplied in the various countries, that in itself should be able to also have an influence on the pricing.
So two things. Are you confident about the uptake of the ring? And then my question to you, what is controversial about this the ring and this other method you've just spoken about?
So do I have confidence about the ring? Yes, I do. I mean, speaking to women across the continent, there are definitely women who have already thought through it and they know that the ring is what will work within their context and fit into their lifestyle. So as a prevention advocate, I think it would be unfair if we end up not giving these women that kind of choice. I guess I don't know if I want to call them controversies, but probably just maybe concerns. I know there are a lot of people who are looking at the ring and they are questioning the efficacy. But I would also, many times when people ask me that, I tell them when we rolled out the voluntary medical male circumcision, I think the efficacy level was at around 60% and it was rolled out. And we still do it now to scale in our countries. So I think it would be unfair for us to look down upon the ring just because of the efficacy. There's a lot of promise in the ring. And also our prevention is still combination prevention. So people would still be encouraged to use condoms because the ring will not prevent pregnancy, it will not prevent STIs. Yeah, so I believe the ring will be a product that will provide an answer or a solution to somebody somewhere. Yeah, and also Kabele, I think the many questions that exist for us for Kabele would be the testing requirements that we've seen, for example, from FDA. Normally we don't want to discuss much because we are also waiting to see what WHO will recommend. And then we see whether this is something that's doable within our countries. There's a question around the tail, like if somebody stopped taking Kabele, stopped using the injectable today, it is estimated that the cabotegravir will clear out of their system after 12 months. So the question is, within those 12 months, what should this person use to continue protecting themselves until they win off Kabele? So a number of implementation questions that are there. But I know within the studies, when we start Catalyst, those are some of the questions that we look out to provide answers for. And yeah, I'm really excited and waiting to see what results come out of this and how that can actually inform programming within our various countries.
All right. Now,
yeah.
John, could you please reassign the interpreters? I think Branley got a little bit disconnected. Could you reassign him as an interpreter? Patricia, I just need you to take a glass of water.
Hello?
Yeah.
Yeah, who is talking?
Ariko is this akwere? Let's ndaza kuvugisha mukanya.
Who is
that?
Amaiba. Aimable.
Yes, I can.
You have a question? Aimable, you have a question?
Hello?
Yes, you have a question.
No question. It's okay. It's fine.
Yeah, then your
maybe
mic is
ask
on.
My question later on.
All right, your mic is on. Maybe you just mute it. Let me also help you to mute it. Okay, so Patricia, I think you've had a short rest. Now my question to you is, what is it that you've not said that you wanted to say to us? What have you forgotten?
What have I forgotten? I don't think I have forgotten anything, but maybe just to say that when these products become available, we have known that the general environment where women are able to access these products can sometimes not be supportive. So we are really looking out to engage the men in these products as they are being rolled out, so that there's knowledge on their part, but also that we can be able to get sufficient support for the women who decide that they are using these products to prevent themselves from acquiring HIV. So we will be counting on the men, on the various stakeholders in the country to create a conducive environment for access. And of course, all this being led by our ministries of health. I think as implementing partners, we support whatever the ministry is planning. So really looking forward, and please look out for results that will come out of Mosaic. If you want to be engaged in these processes, feel free to reach out. I have put my email there. And also my Twitter handle. We will be churning out a lot of this information and letting you know when we are holding our learning forums in the country, so that you can also plug into it. And looking up also to the media to provide correct information to the general population on the same. Thank you.
Okay. Patricia, you are a little bit guarded on your number, your WhatsApp number, or you are the type of people who respond to WhatsApp after 1 week or 2.
All right. So again, you must be having my number. So
I'm not sure. I have so many Patricias here. I don't know whether I really have it. But you can just put it up, please, so that we can, see. Hi, Patricia. Would you recommend simultaneous use of the ring and condom for effective protection? Musembi
yes.
Nzengo. Okay.
Yes, I think I alluded to it somehow to prevent especially pregnancy and STIs.
Okay. Thank you, Patricia. You are that kind lady who has really been nice to us even as we're preparing for this conference and for this particular session. Keep it up and keep it on. And please stay on the call because we are still in the Science Cafe, where now I want to give the mic to Dr. Lazarus Momanyi. Dr. Lazarus Momanyi is a medical doctor, and he's going to talk about two things. One, he's going to tell us about what is called U is equal to U. He's going to tell us what U is equal to U is all about and how Africa is faring on, and maybe how the East African region is doing on U is equal to U. I have had a question for the last 1 month, and that tells me something as journalists, that sometimes we think that some stories are tired. The story on U is equal to U. Somebody asked me, and a very, I would have really not expected that question from that person, because fairly informed guy, more informed than I think I am. And the guy asked me that my house help, I recently discovered that my house help is HIV positive. I want to dismiss her. You can imagine the kind of conversation that I had with that person. And so with U is equal to U, there are lots and lots of hope, and there are lots of ways in which we can confront HIV and many other things. I don't want to make a presentation on behalf of Lazarus. So Lazarus, please come on. But before you do, there are some people who have made it a habit since morning to be going to the waiting room. I will call out your names. Please make sure that your gadget is working so that one of my duties is not to admit you. There are 4 people that I've admitted 10 times. You know yourselves. And again, please, if you are joining, do not join with something called Oppo, something called whatever the name of your high-end cell phone. Please use your name, because we are not going to admit robots. Over to you, Lazarus.
All right, thank you so much.
I forgot something, Lazarus. I also know that you're going to talk to us about this thing called heal. Recently, we saw that you are going to talk to us about something this called heal. We saw what is the science of healing. Some 2-3 people have been healed of HIV, in quotes, so to speak. So after you talk about U is equal to U, please take us through what that means, so that what is it that we as journalists need to know about these claims of heal, or the science of heal. Over to you, Lazarus.
All right, thank you so much, Agan, and I hope you'll allow me to at some point unmute rather not use my video because of the network I have. So, but thank you so much for having me here. My name is Dr. Lazarus Momanyi. I work at the Ministry of Health, Kenya, specifically with the Division of National AIDS and STI Control Program, where I work as a technical advisor within the care and treatment program. And in my work, I specifically support the program to come up with interventions to support people to stay on effective treatment to ensure that they are virally suppressed, and of course towards achieving what we call HIV epidemic control. And so in this presentation, I'll talk, just like Agana said, I'll just give some shed light on what is used to you and what we've done, and also what other countries are doing. And then also delve into this topic on HIV cure. And I think, as Agana said, there's been a lot of myths, misconceptions, information here and there about HIV cure. So I just wanted to shed some light on what is there and what's not there, and what's the science saying, and where are we towards achieving the HIV cure. So thank you so much, and I hope you have me in this presentation. Thank you so much. So I think this is just to take us back a little bit in history, and clearly, as you can see, we've come a long way towards, in terms of HIV and AIDS, first case having been reported some way back in 1981. And a lot of research has really gone in to try and find out what is this virus, how does it behave, How can we manage it? How can we treat it? Can we cure it? How can we prevent it? And I think even in the previous presentation, you've had Patricia talking about some of the new technologies that are coming in to try and prevent the spread of the virus. So a lot of work has gone in, and through a lot of research, again, we've been able to come up with a lot of interventions, including treatments. And probably if you will talk to someone who had HIV maybe like 20 years ago, or a family member had HIV 20 years ago, the little people used to take like a concoction of drugs, I mean, tablets here and there. But we have come to the point at which people are now on a once daily pill. And probably in the presentation, I'll also be talking about some of the newer treatment regimens that are now even giving promise to even having some of the injectable medications that like Patricia was talking about. So globally, I think the takeaway from this slide is that the pandemic, yeah, I think of late we've been talking about pandemics, but really before COVID, probably we mentioned the word pandemic, you'll be talking about HIV. And the pandemic has largely affected the Southern Saharan Africa. As you can see, like out of the 38 million global HIV, people living with HIV, 20 million are in Sub-Saharan Africa. Actually just Eastern and Southern Africa. But now if you combine the entire of Africa, we actually account up to around 70% of the new infections. So as we talk about some of these interventions, some of the work that is going in to try and achieve epidemic control, then you can see why really a lot of effort, a lot of funding has come to Southern Saharan Africa just to ensure that we are able to fight the pandemic. If you actually put this, if I probably switch it and put the COVID-19, it will be a very different story. And it will actually show you that, I mean, Southern Africa was largely unaffected by the COVID-19, something that still puzzled a lot of scientists as to what could have happened. How come that Africa that has such a poor health system, such minimal resources, was actually spared by the COVID-19 pandemic, and yet the countries that boast of very sophisticated, medical systems like Northern America, Europe, and even parts of Asia were hardly hit. And also probably also tell you why probably we were so fast in getting a vaccine for COVID-19, why it has taken so long to get probably like a cure or maybe a vaccine for HIV and AIDS. And because of this disproportionate distribution of HIV globally. So globally, we've been talking about the 1990, and I think this probably has been mentioned before. And this was targets that we're actually supposed to have achieved by 2020, but now these have again been revised, and by the year 2030, we are supposed to achieve what we call the 95-95 target, which basically means that we should have identified 95% of people or of those who are estimated to be living with HIV and put 95% of them on treatment, and suppressed or virally suppressed 95%. So this viral suppression is very important, and I'll be talking about it in a short while, because viral suppression not only ensures that you are able to, the person who is living with HIV is able to survive and live on, and also improve the quality of life. For example, a child who's in school is able to go back to school, go to college, grow up, work, and marry, and have an HIV negative child. But the other thing that it's able to do is what we call achieving of or suppressing communal transmission of HIV. And in a short while, I'll be showing you the evidence that has shown that people who are actually virally suppressed do not transmit the virus to the sexual partners, and that's what we call use-equals-to-you. But also the other goal we want to do is to reduce new infections by to come below 200,000. And this can only be done not only through treatment, but also through some of the interventions that have been mentioned. Things like use of condoms, use of pre-exposure prophylaxis, male circumcision, and other protecting like the vulnerable, like children, adolescents and young girls, where they are hard hit by the new infections or we've seen where the disproportionately affected by new infections, and also to reduce stigma to zero. And so really, these are some of the objectives of the launch of the U is equals to U campaign, to ensure that, one, we're able to motivate people to be virally suppressed. Two, by having them having an undetectable viral load, then they're not able to transmit the virus to their sexual partners, and therefore able to reduce the new infections. But most importantly, also by empowering them with messaging, then you're able to reduce self-stigma and also stigma to people living with HIV from other people who have always seen them as people who are carriers of the virus and are out to transmit the virus. So when you talk about HIV epidemic control, we are basically talking about ensuring that people living with HIV are put on treatment, they live a long and healthier lives. We reduce what we call HIV related mortality or deaths, and we decrease the number of new infections. And it's actually the point at which you achieve HIV epidemic control is where the number of new infections falls below the number of AIDS-related deaths. And I think of late, you've been hearing a lot of talk about Kenya being one of the countries that is achieving or is nearing HIV epidemic control. And it's because of the number of efforts, as you can see there on the left. We've been able to ensure that there's condom access. I think, of course, we have had some challenges of late in terms of access to condoms, but over a long time, condoms have really been available in the public space at no cost. Things like voluntary male circumcision, efforts in reducing PMT, prevention of mother-to-child transmission, PrEP that has already been talked about, ensuring that people are identified and treated for STIs, use of other educational behavioral modifications, ensuring that people are able to test and they know their status. And again, as I keep on saying that you right now, actually, if you are in a number of, for Kenya at least, you're able to walk to a chemist and buy a test kit for 250 Kenyan shillings, which is about $2.50. But also you can be able to get it free from the public health space. And now HIV self-testing is actually accessible across a number of countries in Africa, but also now because of treatment. So if we actually combine all these interventions, then we'll be able to bring down the HIV and achieve what we call HIV epidemic control. Are we there yet? The answer is no, and we still have a lot of work to be done. In between all these are issues around funding, of commodities, ARVs of late, like you've heard of countries that, I think if you talk about Africa, it's only probably South Africa that has been able to increase the domestic funding towards HIV up to 80%. Other countries are still heavily relying on HIV funding. For Kenya, we are around between 80 to 85% domestic funding. So coming down to U is equals to U, which basically means undetectable is equal to untransmittable. It's basically a scientific finding that people who are durably suppressed with an HIV, that's basically a viral load. And this HIV RNA is just basically a viral load test that we do for people who are living with HIV or on treatment. So once you achieve it below 200, and this is the global, probably I'll just remove the word Kenya, this is the global definition that if you have a durable viral load that is below 200 copies, then you do not transmit HIV through sex to your sexual partner. So this is actually a global campaign. The goal is really to ensure that you're able to challenge stigma and pursue health for people living with HIV, and by empowering them to be able to achieve and maintain viral suppression. So it's a messaging campaign just to motivate people who are living with HIV to stay on treatment, take their medications, adhere, and get virally suppressed. And we are telling them that if you actually do that and you are undetectable, then you do not transmit the virus to your sexual partners. So is there science that supports U is equals U? The answer is yes. And here I've put some of the studies that have been done, or some of the, just a minute, I'm trying to disable something that is on my screen. Okay. All right, so this is actually science that has been done. I mean, research that has been done, and some very specific studies that were done. The first one was called HPTN 052, that was done in 2011. that was conducted among 1,763 different couples. By different couples means that for these couples who were enrolled in this study, who are basically heterosexual, means sex between men and women, one of the partners in these studies was negative. So a total of 1,763 couples were enrolled. That means basically a total, we multiply that by 2, it's about 3,400 people who were enrolled in this study. And in this study, they were followed over time, and they were also using condoms. And it showed that all the infections that occurred in people were with the detectable viral load was 17, and one early infection in the RT group before viral load was undetectable, but there was no infection in the people who were undetectable. That's one. Then the other study was called Partner, the second study in the middle, that was done. It's a follow-up study that was done in Europe of 900 different couples. That means one partner was positive and one negative, and they were followed over time. And in this study, actually, they were not using condoms. And when they were followed over time, the results showed that after more than 58,000 condomless sexual acts, when viral load was undetectable below 200 copies, there were no transmission. There were 0 transmissions among these couples. And remember here, they were actually not using condoms. And then the last study that was done was called Partner 2, that was again published in May 2019, which is an extension of the Partner study to collect, but now this one was collecting more information amongst gay male couples. And as you know, usually the transmission amongst men who have sex men is much higher than in the heterosexual sex because of there are a lot of friction. Sometimes they don't have the right lubricants, and because of that friction, there's a lot of tearing or micro tears of the skin. And so transmission is actually much higher when there's sex between man and a man as compared to man and a woman. And in this study, again, there were 0 transmissions among us after 77,000 condomless sexual acts. So basically, all these studies is what informed the global launch of the U is equals to U to show that there's actually science that supports this. And also this is now what also formed the basis for messaging for our people living with HIV. And this is what is formed in the global scale-up campaign. So one of the questions you probably ask, is this something that is accepted by widely, globally? And the answer is yes, again, because this is accepted by some of the leading organizations, institutions that deal with HIV and AIDS in the world, including the British HIV Association, the International AIDS Society, UNAIDS, and also the Center for Disease Control, and 900,000 other organizations that have joined the U is equals to U. So the overall goal really of U is equals to U, one, is to really be able to diminish stigma amongst people living with HIV, that by having the virus does not mean that you are transmitting the virus, and you actually take your medications that are suppressed. It's meant also to reduce the barriers to HIV testing and treatment, to tell people basically that if you actually test and you're positive and you take your medications, you can stay on treatment, and apart from improving your health, also you are not able to transmit the virus to your partner. To increase interest in ART, improve self-esteem, and of course, support health sexuality regarding HIV/AIDS, and also reduce sex partners' concerns. You can imagine that now you have a girlfriend and she tells you she's HIV positive. The first thing, it probably many years ago, would be like, I mean, that relationship should be over. But now we've seen, because of this, people are able to have conversations. The other partner is able to say, I'm on medication, I'm virally suppressed. And the research is actually showing that I don't transmit the virus. And we have seen a lot of couples now who are together, and they have given testimonies to say that one of the partners negative and been able to live together. So U is equals to U basically increases the power of choice to show that I mean, beyond what you already have PrEP, you already have treatment, you have condoms, but you're also telling people that U is equals to U by itself is an intervention to be able to reduce new infections. So does U is equals to U work for all setups? The answer is no. For breastfeeding, our messaging to people is that, yes, ART or research has shown that ART greatly reduces the risk of transmission through breast milk. But research has not established that people whose HIV is undetectable do not transmit the virus during breastfeeding, because remember here the virus now is passing through breast milk. So our guidance and for Kenya and even for most countries, African countries, is that they should be able to follow the national guidelines, which also means that the child should be put on prophylaxis syrup. For people who inject drug use, again, research has shown that treatment or ART reduces the risk of transmission, but does not stop or prevent the person from passing the virus during needle sharing. And we know a lot of people now in sub-Saharan Africa who are using needles, what we call the people who inject drugs, and sometimes they don't even have enough money to be able to buy a clean needle to be able to use. So they end up sharing, and so the risk is usually high. And so use because you does not protect the other person. And then lastly is the needle stick. And again, like people work in the health setup, again, we advise that you should actually use PEP, as even if the person who got the needle injected you, the person who contaminated, even if that actually virally suppressed. So this is just giving the Kenyan experience that we've been able to launch this as a national campaign. We've developed materials. We've been able also to develop a training package for people living with HIV and also the healthcare workers. We've had national training and identified champions across the country. And just to ensure that this message is actually reached, it's cascaded the entire country. We've been able to develop information materials, including like things like t-shirts, capes, fact sheets, and the materials that can actually be put out there to tell people about U is equals to U. And also develop reporting mechanisms. What we haven't done is really to kind of launch like an intensive media campaign. I think in the last meeting that we participated, there were a lot of discussions on how we can really be able to launch like a media or advocacy campaign about U is equals to U to be able to ensure that this message reaches across. It has also been adopted amongst other African countries, like what you're seeing on the screen. This is from South Africa, where they've been able to if we can see big posters talking about U is equals to U, and really a lot of people talking about U is equals to U and some of the benefits. And these are some of the materials that we've been able to develop that are able to replicate the messaging that you're talking about. And studies have actually now shown that have been done in among a lot of even including mostly in African countries, that when healthcare workers talk to patients about U is equals to U, it has been associated with one, improved health outcomes among the people living with HIV, as well as minimizing missed opportunities, and actually a lot of confidence in disclosure and all those things. So it's something that you've also seen research actually saying that, yes, U is equals to U is a powerful messaging tool and a lot of benefits for the person living with HIV and their partners. So I would like to pause here, and I'll want to transition to the second part of my presentation. Again, I don't know whether you want me to continue or I want to pause there for any question.
I think we need to maybe take questions on this, on U is equal to U, if any. Right. So Sifelani Siko from Zimbabwe asks, what has been the impact of COVID-related restrictions on U is equal to U program? And then I'm seeing, okay. I don't know whether it is you to answer this. Among members, has your country ever experienced a scenario where condoms were not fitting your men? Ours were extremely small at some time. So I don't know whether you want to say anything about condoms. I'm so puzzled about, if somebody is making James, Alan, okay, that's done. Somebody here, I think Laura is saying, the shift to HIV treatment containing the DTG is supposed to help you with U is equal to U. How has the DTG been in Kenya? And then just before Laura, there was a question. I think there was a question. Can't really see it. Okay, I would like to get more light on undetectable equals transferable. Hope to catch up with you. Okay, yeah. So anyway, I think just a clarification, maybe if you just want to talk a little bit more about this. Yep.
Again, can I help you a bit?
Please do.
Yes, I've seen the question you are looking for. It's from Okelo Jesus Ojara, and he asks, I am so puzzled about this U equals U because I have never heard it in Uganda, especially in the rural parts of the country among persons living with HIV and even health experts within the country. Is the campaign in Uganda? He asks.
Thank you. So again, probably I could respond to some of those questions.
Go ahead, go ahead.
Yeah, maybe I can start with the question from Sifelani. You asked what has been the impact of COVID-related restrictions on U program. So I would say that in the initial period of COVID-19, and that's probably, if you're talking about Africa, really we're talking about in the first quarter of 2020. Of course, there were all these fears about COVID-19 among us, both healthcare workers and even the people living with HIV. There was actually a big fear that we'll actually have a lot of treatment disruptions in a number of countries where there was those fears. Of course, most of the national programs came and put in place some measures to ensure that there's continuity of treatment. For example, we saw a number of countries opening up, like saying that people could receive more than 3 months of treatment regardless of your status or viral load status, or you're a child or an adult. We saw countries that adopted what we are calling like distribution of ARVs to the community through a number of models. Specifically in Kenya, we actually issued a guidance on the same. And what we saw is that at least we didn't witness very huge treatment disruptions in the continent. Nevertheless, we have seen a number of impacts on the healthcare system that supports HIV. One is that we have seen some of the countries that have experienced drug shortages, especially for ARVs. That meant that people were probably in 3 months and now getting 1 month, and Kenya is one example. We've seen countries where also viral load testing was impacted, because now remember a number of countries or these companies that do support viral load testing shifted their capacities to support viral load, COVID-19 testing and so on. So this had some impact in terms of course, those disruptions ensure that then people who are virally suppressed previously now didn't have adequate medications. For cases where there was no viral load testing, then we are not able to tell whether this person is actually undetectable or not. And therefore, this had a negative effect on what we wanted to achieve with this equals to U. The other question I think I've seen is on from this, I think, just a minute. So you've asked about this campaign, probably that's for justice. You've not had it in Uganda. Yes, so actually a number of countries have been slow to adopting the U equals to U. Like for Kenya, we just adopted this campaign and started talking about it last year. South Africa was amongst the first countries to launch the U equals to U campaign as part of the national strategy. I know that there are efforts through support from PEPFAR in Uganda to be able to launch the campaign, and probably it's probably in the planning phase, but yes, you are right. Really, it hasn't picked up in Uganda, but it's something that really needs to be available. The information needs to be availed to people living with HIV so that they know that actually taking the medication is not only good for them, but also is able to prevent transmission to their sexual partners. The other question, from Chipo, you asked, I would like to get more light on the undetectable equals transferable. So let me just correct that. So U equals to means undetectable is equal to untransmittable. Yeah. And basically, it's what I've mentioned about that. Actually, if you are virally suppressed durably, then you do not transmit the virus. So you asked a question about condom availability. I probably might not have an answer to that, but I can give an example of what you've done in Kenya. every time as we look at our condom strategy, we try to actually get the views of the users. And most of the time actually we go to the young people, and they're able to tell us like what is the right size of condom that we need to procure for them. We've seen also feedback where some of them even want the flavored condoms and so on. So I think it's something probably as a country as Uganda, you will want to engage with the what I'll call the users, and get some of the what do they prefer, and get so that you are actually informed by choice, not really just by what the national program wants. Then I think from Laura, you're asking the shift to HIV treatment containing DTG or dolutegravir is supposed to help with the use because you has been, yes. So in Kenya, you're actually very correct, because remember, achieving of viral suppression is closely related or directly related to the person taking the medications and not the efficacy of the medication. So we have seen that one of the most potent ARV drugs we now have available globally, and also now most of the African countries have adopted, is dolutegravir, what's shortened as DTG. So for Kenya, we've been able to adopt this, and actually we've been able to scale up our transition up to 98% amongst males and 96% amongst females to be on DTG or dolutegravir-based regimens. And this has really played a very big role for us to be able to achieve the very high viral suppression we are seeing in Kenya, which is currently at around 94%, 94 to 95%. So it actually plays a big role. So if you have to talk about use to you, have also talk about how do you put people on the most infectious or effective regimens. I think I've answered all the questions.
Somebody's asking.
There's a question from JJ. Yeah. From James first. Can use because you lead to assumptions which can again cause rise in spread of HIV and AIDS? That's a very valid question, James, you ask. So the way we promoted use equals to you in Kenya, and even also for other African countries, is that we say that it's just one of the interventions. So we still promote what we call combination prevention strategies. And part of the messaging actually we provide is also that use equals you does not protect you against STIs, for example, gonorrhea or syphilis. Yeah, so as much as it may prevent you against getting HIV, you'll still be able, if you don't use condoms and you don't, I mean, the other partner, you don't know their status or whether they have an STI or not, it will not prevent you. So we've been promoting use equals to you, but also telling people that the other combination prevention strategies like condoms are still very relevant, and especially if you're going to prevent sexually transmitted illnesses. The other question is, does use equals you work for all types of sex? The answer is yes. And from the studies that I just showed you, the 3 studies, one of the studies, the first one was conducted amongst heterosexual. That's basically a man having sex with a woman. But the other 2 studies were conducted amongst MSMs. That's men who have sex with men. And yes, so the answer is yes, that use equals you works for all types of sex. Then finally, I've seen the question that does it mean that use equals you, there's no need of using PrEP? The answer is no. PrEP is still very relevant. So the way we have, again, I'll use the Kenyan experience because we have really talked about this campaign in Kenya, is that PrEP, there's a criteria we use to put someone on PrEP. Yeah, for example, if you are in a sexual relationship with the partner and the partner is not on treatment or they're not virally suppressed, then you're supposed to use PrEP. If you are engaged in a risky sexual behavior, or like for example, you have multiple sexual partners, you don't know their status, you are probably like a female sex worker who is having multiple sexual partners, you are a man having sex with men, then you are at risk of and here, remember now, you don't even know the status or the viral load status of the other person, or even whether they're HIV positive or not. So PrEP is still very relevant, but for settings like where like there's a discordant couple, you are married, your husband is HIV positive, you are the wife, you're HIV negative, and the husband is on treatment, and they're virally suppressed, and they're undetectable, then we are telling you that that is actually enough to be able to prevent you or prevent HIV infection. And therefore, we promote use equals you in such kind of settings. So where you know the HIV status of the partner, they're on treatment, they're durably suppressed, then PrEP, use equals you will work for you. But where you are in a setting like what Patricia mentioned, female sex workers, men who have sex with men and they are having many sexual partners, and so on, or even where you're in a relationship but the partner is not virally suppressed, then U equals U will not work for you. Thanks, I'm back. Again, I think I've answered all the questions that were on the chat.
Okay.
Again, can I proceed?
Is asking for a website where they can get more information on the campaign.
All right, so I think for the Kenyan settings, we have developed some fact sheets. I'll be able to share this, the fact sheets that we have. So there's both the global fact sheets, but we also customize some of the fact sheets to Kenya. So if you're looking for global information, then maybe I'll be able to give you a link to where you can be able to access the global fact sheet on News Goes to You. But if you're looking for specific Kenyan information, then the materials we have, we can also be able to share some of the materials we've developed, including the fact sheets.
AVAC, which is spelled as AVAC, also has a lot of, if you go to that website, you're going to be spoiled for choice. So also AVAC, so could somebody just type for me AVAC there, maybe Violet, so that all of us can see what, I mean, that website. It's not AVCS, AVAC. And then I think it's evac.org or something. Just confirm, Violet. Maybe you could even give us a link on where we can get more information on U is equal to U. So I think you can continue.
Thank you so much. Thank you so much again. And also, I mean, thank you, the audience, for very engaging questions. And I think this really just reinforces why this discussion is very important, because we really rely on you to pass the right information. So in my next session, I'm going to talk about HIV cure. And I think as again, in the introduction, you mentioned that there's been a lot of discussions, a lot of news, a lot of information here and there about people who have been cured of HIV. So I think the question I'm just trying to answer is just kind of differentiating what's myth and what's truth about this. And I'll start by giving some case examples of what you've seen or what you've heard. And I'll start with Kenya. And I mean, probably if you live in Kenya, you must have heard of Professor Arthur Bell, one of the most renowned, celebrated actually, scientists, pharmacologists at the University of Nairobi, who in the early 90s made a series of wonder discoveries, including a drug that was called Pearl Omega, which he actually claimed that it converted the positive serostatus of 7 HIV patients. And remember, this was coming in at the time when we had no access to ARVs, because remember, this treatment for free, well, let me say for free, because the patients really literally don't pay for it. It became available around 2004 after President George Bush passed what was called the presidential emergency relief for HIV and AIDS relief, also called as PEPFAR. And therefore, at this time when Nobel was making some of these things, there were no drugs. So you can imagine if you're a person living with HIV and someone tells you, to Konadawa, we've gotten medication that can actually treat you, and you turn from HIV positive to HIV negative. People literally ran. But this, again, later proved to be a myth, because the Ministry of Health initially, of course, supported these clinical trials, but then later they came and dismissed it as a concoction. It was just a herb that didn't have any active drug that was managing or was able to convert a patient from being HIV positive negative. But there was a lot of people who actually went and bought the medications and used it, but it was proved later that actually didn't work. Remember, I'm now talking about a scientist, but here again is now people who actually are called opinion lead or lead opinion shapers, people who shape the opinion. And this is a national figure. In the year again, this is the president who took over from Nelson Mandela. And in the IIS 2016, sorry, 2000 in Durban, he actually publicly rejected, the science that, and claimed that HIV or the virus does not cause AIDS, and because of this, actually, people actually assessed the South African health system. They were saying that because of this reluctance of the government to take up some of the interventions to support people living with HIV, to put resources to buy ARVs, there were thousands and thousands of deaths that happened in South Africa because of some of these statements that were made at the time by the former president for South Africa. So, and again, he actually advised that people should take ARVs with caution, and that HIV is just, should not be given the priority that it deserved at the time, and that probably resources should be allocated to other more important health problems in South Africa. Then I don't know, some of you might have known this man here shown in the picture. He's the former president of Gambia by the name of Yahya Jammeh, who was actually overthrown at some point. And he actually declared in 2007 that he could help cure HIV/AIDS with a herbal concoction, and even went ahead to establish a treatment program, in quotes, where he was administering his concoction. But later it was proved that the concoction had no active ingredient against HIV. It was not working. And people who actually took this concoction and stopped with their conventional medication ended up dying. And there was a lot of revolt from the Gambian people against this cure that had been declared by the Gambian president then. And then some of you must have heard about this man here, this Mzee, known as Ampilikile Masapile, alias Babu wa Loliondo. And he was a self-proclaimed miracle healer in Arusha, Tanzania, who claimed that God, in a dream, gave him the recipe of a herbal medication that could heal all maladies, underline the word all, including HIV and AIDS. And all you needed to do was just take a cup of the concoction. And as you can see in that picture there, he's serving his concoction in the small cups. And people actually crossed, like from Kenya, people literally crossed the border and went in caravans to go, and people had cancers, people had diabetes, people who had childhood illnesses. And we have had testimonies from people who actually had HIV and AIDS who went to Loliondo and they took this and they stopped taking the ARVs. And immediately they stopped. When they came back after a few months to 1 year, most of them were on their deathbeds and they were very sick and had to go back to medications. So again, it came to prove that this was actually against a concoction and it had no active ingredient, or it was not a cure for AIDS as was claimed. Fast forward to modern day, and I just saw this someone who calls himself Shepherd Bushiri. I don't know if there's anyone from here from Malawi. And he actually claims he's a pastor or a prophet. And he claims to have cured people of HIV, changed fortunes for the impoverished, and interestingly, is able to walk on air. And I'm just giving these examples just to show the wide range of the people who can potentially promote misconceptions or myths about HIV cure, where sometimes or most of the time these are not backed by science. And even in the Kenyan setup, we've actually seen people who have called for large crusades and have said they've cured people of HIV. And of course, our patients, they'll always follow what the opinion leaders say, whether you are a pastor, it could be a pastor, it could be a politician, it could be a traditional healer, and so on. And most of these patients are really desperate for a cure. So they'll stop taking their medications. And sadly, the fact is that we've seen that most of the time they come back when they're very sick. And unfortunately, some of them actually end up dying by stopping their medications. So what are the truths about HIV cure? So let's first of all start by defining what is an HIV cure. What do we consider as an HIV cure from the scientific perspective? So basically, there are two types of cures, or rather what we'll want to achieve as an HIV cure, whereby there's what we call a functional or remission. If you've had a patient who has had cancer, you'll always hear the doctor talking about remission. Or this is whereby probably like you have cancer, let's say cancer of the stomach, and you undergo radiotherapy or chemotherapy. And the doctors will check for your cancer cells after maybe like 2 years. And they'll tell you that we have done some samples and you've not seen the cancer cells. But it does not mean that you have actually been cured of cancer. And most of the time, you'll actually see that some of those people relapse and have another bout of cancer. So for HIV, a functional cure will be whereby you have very small numbers of HIV-infected cells that are below detection when you are off treatment. So this person was on treatment, and if you take them off medication, you still see undetectable viral load. But if you do the DNA, you'll find that they still have the DNA of the virus or the viral particles. But then the most ideal, or what is desired of an HIV cure, is what we call a sterilizing cure. Yeah, and this is where you have complete eradication of the virus from the body. Yeah, so if you ask people who are on treatment, they'll tell you that they've been done a viral load, they've been taking the ARVs, they've been done a viral load, and the viral load is undetectable. But remember, they only remain undetectable as long as they're taking their medications. So you'll only say you are cured or you have had a functional cure if you take you off your medication and you still continue being undetectable. But now for us to be able to say that you're completely cured, it must be what we are calling a sterilizing cure, whereby you've been able to eradicate all the virus from your body. And that means that even in the future, yeah, regardless, or even if you have to stop the medication, there is no chance that actually the virus can start replicating in your body. So have there been cases where we've been able to achieve a sterilizing cure? The answer is yes. And there are only 2 cases that have been reported in the world. And the first one I'm going to show you is what we call a patient from Germany called Timothy Ray Brown, also known as the Berlin patient. And he was diagnosed with acute leukemia, myeloid leukemia in 2006, after living with the virus for 11 years on ARVs. He was initially put on chemotherapy for his leukemia, but it failed. So he underwent 2 bone marrow transplants. And later, when researchers, remember, he was undergoing bone marrow transplant, not for his HIV, but for his leukemia. But later, scientists were puzzled because when they tested or they checked his blood, they never found any traces of the viral genetic material. Or they only found very small traces, and none of it was able to replicate even after he stopped taking his medications. Hence, he was actually declared cured. Unfortunately, he died in the year 2020 because of cancer, not because of HIV, but this is the first documented case of someone who actually got cured because of HIV. And scientists had a lot of, actually they say is one of the most studied cases of HIV because they had to test like what could have gone on. So there's a lot of theories on what could have happened, that probably when they were doing the bone marrow, they also had to put some chemotherapy. It made his immune system forget. The chemotherapy or the bone marrow transplant might have changed his immune status of some of the cells, and therefore making it very hard for them to be infected with HIV. So there were a lot of theories, but there was no really answer as to what might have happened to him. And then this year, in one of the most renowned global scientific conferences called CROI, which stands for Conference of Retrovirus and Opportunistic Infection. So CROI is like, it's like the gold standard of the world. If you have anything around research, cutting edge research, that's what is usually presented. So this was of a middle-aged woman, again, of mixed ancestry, who had developed acute leukemia. So you can see a similarity with the first case, and had been on treatment for 4 years. Then in 2017, she received a transplant of umbilical cord blood stem cells. 3 years post-transplant, the patient stopped ART, And 14 months down the line, no HIV was detected in the patient, and only some traces, of DNA that could not replicate. So she actually stopped treatment and is actually also considered cured. So in the entire world, there's what the prophets will say, there's what the healers will say, there's what the politicians will say. But from the scientific perspective, these are the only 2 documented cases of people who have been cured, of AIDS or of HIV. So as I come towards the end of the presentation, so what can I point out? That one, there are 2 types of, and I mean, why is that HIV is so hard to cure? And one of the reasons that has been given forward by science is that it hides in reservoirs. Reservoirs are like some parts of the body where even the ARVs is very hard to penetrate. Think like lymph nodes, somewhere deep inside the bone marrow. So you can treat it, you can bring it to an undetectable level within the blood system, but you are not able to reach and eradicate the virus or stop the replication within the reservoirs. So, and this is some of the things that the science we give to even our patients and break it down to tell them that by being undetectable does not mean that you are actually cured of the virus. So you can see on the left, this is a person who is not on ARVs. The DNA for the virus is positive. They have RNA positive because now the virus is replicating and they're able to detect the virus in the blood. And if actually they don't take the medications, regardless of the time it will take, they'll progress to severe immune suppression and what we call advanced HIV disease, and they'll die. Of course, there have been documented cases where people have stayed on without treatment for a very long time, probably because of the immune system buildup and all that. But if you really followed what we call the natural history of HIV, is that without ARVs, you will actually progress and die. And that's what happened in many years ago when there were no treatment and there were mass graves and people died. And so basically ARVs have been a game changer. And what basically ARV does is that it switches off, the virus replication. So it goes to what we call latent infection, where you will still be HIV positive, but you have no viral load replication. And that's why you're saying you're now RNA negative and you're not able to even detect the virus. And now we have actually machines that can now detect viral loads of up to below 20 copies per ml. And therefore, it means that people can actually survive with HIV, live for many years, and probably die of something else and not HIV because of ARVs. So what happens is that you should see the virus as like a spring. What happens when you press a spring down as you apply force is that the spring comes together and it stays there. But the moment you release the spring, then it basically recoils back. And that's the same thing that happens every time a patient who is living with HIV stops medication. As long as they're on treatment, they'll be virally suppressed for years, unless maybe they develop either treatment resistance or they stop taking their medications. But the moment you interrupt treatment, then the virus just goes back, the factory switches on and it replicates. And therefore we have seen patients who have been on treatment and they go somewhere, they're prayed for, they go somewhere, they take some herbal medications. And most of the time when they come back, they'll either be having TB or cryptococcal meningitis. And most of the time actually, we end up losing those patients. So is there hope that there'll be a cure? The answer is yes. There's a lot of research going on around treatment, prevention, cure. So for HIV treatment, we are basically trying to find which is the most effective way of treating the virus so that you can be able to boost the immunity. So like when I had someone asking about dolutegravir, which is like the newest drug. So every time research is going on trying to establish which is the best drug, which is the better drug, which someone does not need to take very frequently, that is highly potent, that is less toxic, and that is friendly to the person. And therefore, through research, we've been able to bring newer drugs in the market, including like the recently launched what we call pediatric dolutegravir, that now is a child-friendly regimen that children can actually take, and they're able to be virally suppressed. There's also a lot of research going on, like what again was mentioned in the previous presentation, around effective methods of preventing HIV. Now there's a lot of research going on around, PrEP, the long injectable cabotegravir, the dapivirine ring, and microbicides, a lot of things, vaccines, and so on, just to be able. But then there's also a lot of research going on around trying to find the cure, like something like would be like the endpoint, something that treatment that you provide to people and you eradicate the virus, as I mentioned. But unfortunately, there's been a lot of steps that have been made in the first two types, that the HIV treatment and prevention. Unfortunately, the HIV cure, there's still no promising cure that is there available, that is able to, we can be able to say that it's actually available and effective, that can be able to cure people of HIV. There's been, when it comes to treatment, there's a lot of research going on, and now there's been a lot of breakthroughs in the market. And we've had, if you follow the Kenyan media, for example, you heard that now we had the first trial of the long injectable ART in Kenya. And we had the first patient who received it in Aga Khan about 2 months ago. So, and what I'm showing you, there's some of the approved, that have been approved by FDA and also the European Medical Association to be effective, and now actually are allowed to be used in humans. And now we have like the cabotegravir, also known as CAB or vocabria. We have the one that's injectable called Amplitude. And then now we have the Cabenuva, which is cabotegravir and ripivirine, that is used as an intramuscular injection given once to twice a month. So you can imagine someone who's been taking their drugs every day for 365 days. Now they only need injections, like 6 injections in a year, and they're good to go. So this is expected to improve adherence to treatment. But again, for Africa, we have a long way to go, because remember, some of these medications, for us to be able to access them, the patents of the original have to be removed, because we are not able to buy the originals because of the resources. But a number of probably the countries like in Europe and America will be the first ones to adopt and use some of these medications and so on. There's also a lot of research going on around long-acting tablets. We have also a lot of research going on around things like patches, something like the Jadel, the one they use for family planning, that's put under the skin, and it's able to release the drug, what you call the slow release, and so on. So these are all promising researches and breakthroughs. But remember, again, these are not cures. These are just ARVs for treatment. And so we still don't have a cure. There's a lot of research also going on around vaccines. And when you talk about vaccines, there are 2 types of vaccines. There's both a preventive vaccine, a vaccine that you're given, like now what you get for COVID, that prevents you from getting the virus. But there's also a therapeutic vaccine that you can actually be given, and it cures, or it blocks the replication of the virus and it cures you of the virus. So again, unfortunately for HIV, there is no licensed, effective, and safe vaccine. A lot of research has gone on, including in Kenya, in IAVI, in Kavi, in Kemri, across the world. A lot of research has gone on around HIV vaccines, but unfortunately we don't have a vaccine. Maybe there will be lessons to learn from COVID-19, because COVID-19, you only had it like less than a year, and there was already a vaccine. Maybe there could be some lessons we can learn from that, but that will also depend with a lot of goodwill, global goodwill, But remember, again, HIV, as I mentioned, not in a political way, but there's a lot of disproportionate distribution. It will need a lot of research funding to be able to get a cure for this. And of course, maybe it might need some intervention, some supernatural intervention for us to get a cure for HIV/AIDS. Thank you so much. And back to you again.
Oh, yes, that is Lazarus for you. Thank you. So articulate, so informed. And that basically means that we've had a very informative presentation. And I think the whole of Africa, wherever you are, by the way, before I say that, I hope everybody is taking advantage of the interpretation that we have. We have both French and English. So do not stress yourself with English if you're not very good in English and you speak French, and do not stress yourself with so much French and English is your fault. So thank you for that presentation, Dr. I'm told that interpretation has stopped because one of us is not assigned as asked. Okay. So that basically means we are in trouble here. Okay. If the screen share is disabled, we can remedy the matter. Interpretation has stopped. So if the screen share is disabled.
Okay. I've unshared.
Yes, I do hear you. Okay, I had spoken with them. Okay.
Bonjour, c'est Humator. Je suis pas disponible à ce moment.
Hi, John. John Riaga. John Riaga.
Yes, again, sorry.
You are the host. Can you pass the host status to Eric? Okay. Because we can't continue without interpretation.
But Eric is set up, I can see. He's unable to. Okay.
He wants to be the host. Make him the host. So just let him be the host. You don't know how to do it?
1 minute.
Sukanya, are you on call? Sukanya? Eric, you can tell him how to pass the hosting rights to you. Or he's using two devices.
Yeah.
Oh, mine.
The other one has no sound.
That should not happen. Take him slowly. Take him slowly, one step at a time. So start with the first step. So the first step is, please click on the list of participants. Is that done? John, is that done?
Hold on.
You are not communicating to us. Say yes or no.
Yes, I have.
Now, that is step one. Step two, look for Eric. Have you found him?
Yes, I have.
Yes.
So it is not giving me the options.
So have you seen more in the first place?
Yes, down there, yes. So
okay.
Allow to
So
unmute.
Eric, after he has seen more, what is he supposed to do next? So John, are you seeing that?
So when I go to more, what I see is ask call to unmute, mute participants on entry. It has nothing to do with the interpretation.
Okay. So Measure Science is now the host. Eh? Yes. And I'm not Measure Science.
You have information science.
I am not Measure Science. It is Hugh who is Measure Science.
Okay.
Oh, hello, John. I just made Branley interpreter again.
Okay, and what about Eric?
Eric is still interpreter.
All is well now. Thank you. Sorry, Hugh, for waking you up again.
Okay, everything all good?
Yeah, John, don't have two don't have two connected devices, because you are the one who is holding us at ransom, because you are the guy who has got all the rights. So you have taken all the rights to yourself. Nobody else can penetrate.
Okay, I'll log off